Hi everyone, my name is Nilofar Kazi. I'm the Director of Education here at the Center for Innovative GYN Care. Thanks so much for joining us today, as September marks Gynecological Cancer Awareness Month, and with nearly 100,000 women being diagnosed with GYN cancer every year in the US, today we wanted to focus on raising awareness for GYN cancers. Joining me today is Dr. Natalya Danilyants, also known as Dr. D. Dr. D is a board-certified, fellowship-trained, minimally invasive GYN surgeon and co-founder of the Center for Innovative GYN Care in Rockville, Maryland. Dr. D completed her residency at George Washington University, where she served as chief resident and received fellowship training in advanced retroperitoneal laparoscopic surgery through the exclusive Johnson & Johnson Ethicon Endosurgery program. Thanks so much for joining us today, Dr. D.
Thank you, Neil. Thank you.
Of course. So as I said, for GYN Cancer Awareness Month, we're focusing on raising awareness for screening and prevention. And there are 5 main types of GYN cancers. So if we'll see in figure 1 here that the first type is cervical cancer, which occurs in the cells of the cervix. And I'm just going to give a brief overview, and then Dr. D will go into detail. And cervical cancer is the only type of GYN cancer that has a screening test. And this is important to keep in mind when thinking about the other types of GYN cancers because they don't have a screening test. So it's so important to check for warning signs and to understand the risk factors for the other types of GYN cancers. So vaginal cancer occurs in the cells that surface the vagina. Vulvar cancer occurs in the surface area of the female genitals. Ovarian cancer occurs either near or on the ovaries. And then finally, uterine cancer, which is also known as endometrial cancer, occurs in the layers of the cell that form the lining of the uterus. Now, uterine cancer is the most common type of GYN cancer. And overall, it's the 4th most common cancer in American women. According to the National Cancer Institute, there will be an estimated 65,620 new uterine cancer cases this year alone, which will account for about 4% of all new cancer cases. Now, before we start our segment, I like to take this moment on behalf of the CIGC family to dedicate today's event to Brianne Hunter, Dr. D's former patient who recently passed away from uterine cancer. Brianne's mother prepared a statement that I'm honored to present on her behalf. So this is, okay. My daughter, Brianne Hunter, passed away from uterine cancer in July. Brianne was active and loved the outdoors. She had gone skydiving, whitewater rafting, and completed a triathlon. She traveled through Africa, China, Croatia, and other parts of Europe. Tulips were her favorite flower. As a human resource professional, she was educated and successful. As a daughter and older sister, she was loved ferociously. Brianne's passing has promised conversations about women's health in my own family. And I am sharing her story in the hope that it starts those conversations in many more families. Brianne knew she had fibroids, but she also felt in her gut that something else was wrong. She brought up her concerns with her doctor multiple times, but she was continuously dismissed. Because she trusted her doctor, she didn't pursue that gut feeling. If I had known she felt this way, I would have pushed her to trust her instincts. When performing Brianne's surgery earlier this year, Dr. Danilyants discovered stage 4 uterine cancer. Brianne was hospitalized and passed away shortly after her surgery. She lived a full life. She lived a life so full in her short 43 years. While it seems unfair that she is no longer here, I take comfort in the fact that she lived her life to the fullest. Thank you so much, Ms. Hunter, for sharing that statement with us. And I know Dr. D knew Brianne, and although I didn't know Brienne personally, I can assure you that through these words, Brienne's legacy and energy has touched me and our viewers today. So thank you again for sharing that with us. In honor of Brienne Hunter, I like to turn to the audience and ask you all, how has gynecological cancer touched your life or the lives of your loved ones? And Dr. D, now I'd like to transition to you. If you could just give us an overview of the main symptoms of the different types of GYN cancers that I just went over, and the characteristics of them.
Sure. So as far as, cervical and uterine, because of the location of the cancer, a lot of times it presents as bleeding or abnormal bleeding. But because bleeding, can be caused by many different conditions, and certainly a lot of women experience abnormal bleeding or heavy bleeding, a lot of times it's sort of overlooked, right? It's been thought that, okay, maybe I'm just having bleeding because of stress or some other hormonal issues, and so it may not be diagnosed as quick as it should be. So that's cervical and uterine. With ovarian cancers, typically, the symptoms, or it's actually asymptomatic for a long time, and that's why ovarian cancer, a lot of times, it's diagnosed at an advanced stage. And symptoms are very vague and non-specific. It could be, poor appetite, or it could be bloating or pain. So it's not very specific to GYN, as opposed to bleeding, which that's sort of GYN related. Vulvar cancers, because they're on the outside, right, on the external genitalia, most of the time the patient will notice, an area that looks different. Maybe it's itches, or maybe it's uncomfortable, maybe there's some discoloration, so that's when it's diagnosed. And these cervical and vulvar lesions are typically, or a lot of times, they're diagnosed when they're precancerous. In this country, and in most developed countries, Pap smear is part of routine care. So a lot of these cancers are discovered in the precancerous stage when they're very treatable. And even when it's in the cancer stage, a lot of them are very treatable as well. So it's rare, I would say, in this country to find advanced cervical or vulvar cancer.
Just quickly, I don't know if you went over this just now because it was breaking in and out, but could you go over the risk factors for these types of cancer for us?
Sure. So the cervical cancer and vaginal cancer and vulvar cancers, those are typically caused by HPV virus. So it's a virus that's been known to cause these cancers. And that's where the screening process comes in. The Pap smear screens for the virus as well as for the abnormal cells. Risk factors are decline in the immune system, which doesn't allow your own body to fight this virus, right? So someone who has HIV or any other condition that lowers the immune system. Smoking definitely does increase the risk of cervical and vulvar and vaginal cancers. Ovarian cancers, there's not, other than family history, there's definitely can be a genetic component to ovarian cancer, and certain gene mutations increase the risk of a woman's risk of ovarian cancer, but majority of the ovarian cancers are actually not genetically linked, or at least not linked to a specific gene, so they just form sporadically. Uterine cancer, there are known risk factors. There are several types of uterine cancer. The most common is the one in the lining, which is what you mentioned. So that's called endometrial cancer. And those type of cancers are very common. They typically present in women who are postmenopausal, meaning that they've already gone through menopause, and then they start bleeding, which kind of alerts the patient that something is going on. Obese or overweight patients are much higher risk for uterine cancer, even in the premenopausal period. So women who are not menstruating regularly, such as women with polycystic ovarian syndrome, a lot of which are also overweight. Because you're not regularly turning over that lining is growing over a period of time. And so that can lead to cancer, development of cancer.
Okay.
Sarcomas, which is uterine cancer of the uterine muscle, are much more rare. And again, there's not necessarily a link, a risk factor linked to that type of cancer.
What about for women who have fibroids? Does that increase their risk of GYN cancer, or is that not relevant?
Well, the fibroids don't turn into cancer. They don't become cancers. However, it can make diagnosing cancer much more complicated, right? Because if someone has known fibroids and they have abnormal bleeding, nobody's thinking, well, maybe there's something else going on. And that, unfortunately, is what happened in Brienne's case, is that she had known very large fibroids. So there was no alarm when her imaging was showing large masses, because yes, we already knew she had fibroids. When she was having abnormal bleeding, her doctors didn't feel like that was out of the realm of sort of the symptoms, what you would expect with fibroids of her size.
Right. So let's go in a little more detail with uterine cancers. In Figure 2, we'll see that based on the National Cancer Institute, white women, so uterine cancer is slightly more common amongst white women. However, the death rate for Black women is much higher. Now, according to the Carolina Endometrial Cancer Study, Black women are 93% more likely to die from uterine cancer than any other racial group. And that I thought was an astonishing statistic. And it's mainly because they're more frequently diagnosed at a later stage. And some of the factors that contribute to this racial disparity are lack of medical coverage, later diagnosis, unequal access to cancer treatment, and comorbid conditions like you went over just now, Dr. D. So could you give us more details on the trends you see for patients who end up having uterine cancer? You were talking about Brienne's case just now, briefly.
Yeah, I mean, first thing, when I usually see someone with abnormal bleeding and fibroids, a lot of times we recommend, even if the plan is, for example, to do a hysterectomy, a lot of times we will recommend biopsy of the uterine lining. And there's always questions come from the patient saying, well, why do I need a biopsy? I'm taking the uterus out anyways, right? Mm-hmm. And the point is that you want to get a biopsy to know if there's already cancer in that uterus, because that may change completely your treatment. Obviously, you would not do a uterine preservation if there's already cancer in the uterus, or maybe there would be a different way that the uterus is removed. Or maybe sometimes the ovaries need to be removed. So there's, it's a different surgical management. It's important to know that there's cancer already in the uterus prior to the surgery. Mm-hmm. So biopsy is very important. And
now, in Brienne's case, Dr. D, from my understanding, prior to her having surgery, there was a certain time period of delay in care where she saw herbal treatments. Could you talk a little bit about that?
Yeah, I know that she had long-standing history of fibroids, and I think that's where the alternative treatments came in. Is that trying to avoid surgery, and that is very common. I see that in patients all the time. Is obviously no one likes to have surgery. And if there's a way, whether you go online or maybe somebody recommends it, to say, well, maybe there's another way, non-surgical way to shrink these fibroids, let me go ahead and try to do that. And I try to discourage patients from doing that because I know that it doesn't work, not for large fibroids. So surgery is unfortunately the only way to remove them. So there was, that part of delay. And then, she shared with me that even when she went to see the doctors, because she was experiencing actually kind of abnormal discharge and bleeding that she wasn't having previously. So that there was a change in her symptoms, right? Despite that, she's had these big fibroids for a long time. And she went to see doctors and they checked her for infection, but the biopsy was never done. So, it's hard to say, in retrospect, because of the type of very aggressive cancer she had, that, if she had the biopsy done 6 months prior or a year prior, would have, it may not have, changed her outcome overall, unfortunately, because of the aggressiveness of this type of cancer. But, certainly it could have, given her more time, I think, with her family, and just more time to kind of think things through, because that's very important. So anyway, so we did the biopsy, and that's when the diagnosis, came up, because prior to that, when I spoke with her the first time, we actually were talking about a myomectomy. We had it was during COVID. I think it was in March or April. And it was either an e-visit or a phone consult. And I remember, she said she wanted to preserve the uterus for possible fertility. So, this whole time we're talking about myomectomy, and then, the biopsy comes back, which completely, changes everything.
And from your encounters with Brianne, and clearly from Miss Hunter's statement about Brianne, it seems like Brianne was very fierce and very bold, and she typically wouldn't ignore her gut, right? But it seems like she trusted the doctor, and that also may have contributed to the delay in care. But like you said, in retrospect, we can't pinpoint one thing, but it's good to be aware of the different factors that play a role.
Yeah, absolutely. I think definitely, if you feel something is wrong and somebody's telling you that there isn't anything wrong, or let's say you're not getting the answers, and all you're getting is that all your tests are all normal, then, getting a second opinion. I mean, we'll always talk about second opinions, but definitely going to see a different provider, to figure out what is wrong, because certainly it's simple to do a biopsy, because that changed everything, right? That one biopsy completely changed everything.
And I just want to point out to our viewers that we did receive permission to use Brianne's story today from her family. And we wanted to share it, not with the purpose of scaring anyone, but just to provide a human example of the impact uterine cancer has on the lives of the patient and the family. And also just wanted to circle back to the point about Brianne knew something was wrong in her gut, and it's so important to not let anyone, even a doctor or a healthcare professional, silence that gut feeling. Because no one else can feel what you're feeling. No one else knows your body more than you do, and no one else hears that whisper that's telling you, okay, something's wrong. And so that's why it's so important to get a second opinion. And I just wanted to pose this question for our audience. Have you ever felt like something was wrong at your core, but a healthcare professional dismissed your concerns? Now, Dr. D, what are the ways? I know you briefly mentioned how to screen for GYN cancers, but what are specific ways to screen for GYN cancers, and what should women be asking their doctors when they go to their well woman visit, that annual visit when you go to your OBGYN?
Yeah, obviously pap smears, right? So we're screening for cervical cancers, and those are typically done. I mean, women that have OBGYNs do get pap smears. So I think in that area, I think there's pretty good care. Other things, for uterine, and just even for screening for benign conditions like fibroids, we know that pelvic exams are useless when it comes to everything that we can't see, right? So we can see the cervix on the speculum exam, and we can see the external genitalia on the external exam, but you really can't see the uterus, you can't see the ovaries, you can't see fallopian tubes. And manual exam, which is when the doctor feels around, are very limited. They're limited in very thin patients, and they're especially limited in heavier patients. So you can't really base on pelvic exam by manual exam say that things are fine. And remember, a lot of patients may not voice their concerns. Maybe they're experiencing something, and maybe they don't feel comfortable saying it to the doctor. Maybe they'll feel that they will be just dismissed and they will be told that things are fine. It's part of normal symptoms. So again, ordering an ultrasound, I think, is the first step. So even if there's no complaints, if the patient is just coming in for their annual exam, and then there is no suspected issues, I think a pelvic exam would be a good start. Because at least it allows you to see if there's fibroids, if there's cysts, if things at least appear normal on the ultrasound. And then, patients, high-risk patients, they need to be counseled. So patients who are overweight, who don't have regular periods, so those are all patients at high risk for uterine cancer. We need to counsel them and tell them that, your weight can increase your risk. And that's very important, and provide, nutritional counseling or exercise. So it's not just that you're meeting this person doing a pap smear. It's just so much more than that. A lot of it is about education, right? Educating the patients and really making them understand, what kind of things can occur, even in younger patients. It's not only a postmenopausal issue. So.
And I wanted to go back a bit and talk about this fear of surgery that a lot of us have. I myself have it. And so as a surgeon, what advice do you have to kind of dispel that fear of surgery that we have?
Well, not all surgery has to be invasive, and most surgeries are done minimally invasively. I mean, in our practice, we do everything with smaller incisions. Surgeries are outpatient, so it's a much different perspective. But I think a lot of patients don't realize that there is a minimally invasive option. And so for most people, surgery means big open cut and pain and long recovery. And it doesn't have to be like that. It doesn't have to be that way. Even for some, early stage malignancies can be done minimally invasively. And especially, of course, for benign non-cancerous conditions, minimally invasive surgery is the best way to go. But yeah, I mean, no matter how brave a person may be, of course, no one wants to have surgery. But you have to, in order to discuss whether surgery is the right approach, you really have to talk to a person that does surgery, right? So, because if someone hardly ever does surgery and mostly does conservative management, if you talk to them, they're probably going to recommend conservative management. That's just the way things are. But when it comes to fibroids, when it comes to abnormal bleeding or pelvic masses, those things are not appropriate because these things can get worse. Cancer obviously advances, so there's conservative management, especially without the right diagnosis, can be very detrimental.
Yeah.
Also, I just kind of wanted to add about Brianne. I mean, I think that, she was a very brave person. I, of course, met her for a short time, and I think majority of the time we had together was unfortunately after her surgery, during her hospitalization because of COVID. She was really alone. She felt very alone, and of course, having that diagnosis and not even have the family be with you every day in the hospital is, I can't even imagine that. So I feel like I was visiting a friend, every day when I was seeing her in the hospital, but she was very brave. She never cried. She was, very stoic, and she just a very, very nice and smart and kind person.
She was a warrior.
Yeah.
So I thank you for sharing that, Dr. D. So I just wanted to read some of the comments here. Nicole said, it happened to people I know. I believe the question was, If you ever felt like something was wrong, but a healthcare professional dismissed your concerns. Nicole said it happened to people I know, or they were misdiagnosed. And then Lola said, I had a UFE procedure, which only stopped my heavy periods. See any other comments here? But going back to your point, Dr. D, on just delaying care, could you talk to us a little bit about how that can be detrimental to patients who may have cancer or fibroids or any of these GYN conditions and cancers?
Yeah, because these conditions progress, right? So if we don't do anything about it, the conditions don't stay still. They keep going forward. So whether it's fibroids that are non-cancerous tumors, they continue to get bigger. If it's cancer, of course, it continues to grow, which means spread beyond its point of origin. So it's kind of it's a life or death situation, right? And especially if we're talking about cancers that are very treatable when they're in an early stage. Things like, cervical cancer, like I mentioned earlier, but also cancer of the uterine lining. It typically presents early because it presents as abnormal bleeding, but certainly if you ignore it, it'll progress, right? And the treatment is going to be very different. It could have been just surgery, but if it's advanced, then we're talking about other treatment like chemotherapy and radiation, things like that. So it's very important to diagnose it early. Very important.
And on that point, in terms of delaying care, we recently, a recent survey, the Women's Health Survey, which is still ongoing actually, I pulled a statistic from it, and we found that of the respondents that were diagnosed with fibroids, 47% of those who were under the age of 45, so childbearing age, indicated their diagnosing doctor recommended watch and wait. So of that pool of respondents, close to 80% indicated their symptoms got worse during that waiting period, during that watch and wait period for their fibroids. So again, that just speaks to the fact that waiting just worsens your symptoms and becomes detrimental to your overall condition in the long run. And
sorry to interrupt, but it definitely is important to pay attention to your symptoms, but also if, let's say, if it's fibroids, it's important to continue, if you're for some reason not doing surgery, not doing anything about it, continue imaging. Because I've had multiple patients that, they changed their diet and they felt like their symptoms got better. But in that period of time, they actually did not get any imaging. And when they finally did, their fibroids were much bigger. So that perception of better symptoms can be, maybe diet did improve the bleeding, right, the symptom, but it doesn't mean that the disease didn't continue to progress, right? So it's important also to follow up on the actual condition, whether it's fibroids or cysts, to make sure that it's not getting worse.
That's a really good point. Lola James had a question. She is asking, so are you suggesting to get a biopsy? I still have large fibroids and I am 57, but no periods.
Okay. If there's no bleeding, so the biopsy wouldn't be of the fibroids, right? The biopsy that we're able to get is of the uterine lining. Now, sometimes if there's cancer in the lining, of course you would get that through the biopsy. In Brianne's case, her cancer didn't originate in the lining, it originated in the uterine muscle. But because it was so advanced, it actually was already present in the lining as well, and that's why the biopsy was able to pick it up. With very large fibroids, typically I recommend removing the uterus, because just having large fibroids and let's say you don't have periods, can have impact on other things: frequent urination, lower back pain. It can alter bowel movements. It can just be very uncomfortable. It can put pressure on the ureters, which are tubes that go from the kidneys to the bladder and can cause dilation of the kidneys. So there are other, what we call bulk effect, right? The effect of this large mass being there that shouldn't be there. You can develop blood clots because of the pressure that this large mass puts on the blood vessels. So these are all kind of non-bleeding issues. So if you're not having abnormal bleeding, or if you're not having any periods or postmenopausal bleeding, you don't necessarily need to have a biopsy, because that's what the biopsy would be looking for, abnormal cells causing the bleeding. But removing the uterus may not be a bad idea, because with a very large uterus and very large fibroids, you could be more likely at missing some other condition, even by imaging. When you get an ultrasound, maybe they can't see the ovaries because the fibroids are so large, and maybe one of the ovaries is developing some sort of mass or tumor. So, I would recommend it for those reasons.
Thank you, Dr. D. Just going back to your point earlier, one of the reasons women may delay a necessary surgery is because they may have been told that an open or abdominal surgery is their only option. So, for example, women with a high BMI may have been told that they're not a candidate for laparoscopic surgery, or they may not have even been informed of that option. If they know about minimally invasive procedures and that they are a candidate, then they may not delay care. And that's not to neglect any other reasons that women may delay care, but this is one of the common reasons. And so my point is that minimally invasive surgical options are possible for women of all shapes, sizes, and ethnicities, colors. Just, it's for everyone. And Dr. You can definitely attest to that.
Yeah. I mean, there's not contraindication to laparoscopic surgery. I don't get these comments so much anymore, but about 10 years ago, patients would come in and say, my doctor told me I was not a candidate because, a uterus greater than, let's say, 15 centimeters should not be done laparoscopically. That's not true. There's not a rule of thumb that it has to be a certain size to do it laparoscopically. I always tell patients, it really just depends on the doctor's comfort level, right? So, of course, the larger the uterus, the larger the mass or fibroids, the more technically difficult the surgery becomes. So, whereas a normal size uterus, maybe 90% of general OBGYNs can do that surgery laparoscopically. When it comes to a 20 centimeter uterus, which is about 4 or 5 times the normal size, only a small number of people can do it laparoscopically. So it's just a matter of asking the right person. Same thing for patient size, right? You can be morbidly obese and still have laparoscopic surgery, and there's actually benefits to having laparoscopic surgery, or additional benefits if you're obese, because you don't have to worry about big open cut, having wound infection, right? Also, it's important to have a skilled surgeon do that surgery, because especially for a heavier patient, maybe being under anesthesia for a prolonged period of time can be more dangerous than for a normal sized patient. So all of these, there are certainly risk factors, right? There are risks, and patients' health status can put them at a different risk category. But as far as performing surgery minimally invasively, it can be done. It should be done. It's just a matter of going to the specialist to do it.
Absolutely. And always, always, always seek a second opinion if you can't find that specialist. If your OBGYN, your go-to OBGYN is not that specialist, always seek a second opinion. I have an audience question. So for those of you who have experienced symptoms like severe period pain, heavy bleeding, and just general overall pelvic pain, have you delayed getting your symptoms evaluated? If so, why? I can actually, okay. I was going to say I can answer that question for myself, in that I think the delay in getting care stems from the fear of, oh, it may be endo or it may be this diagnosis. So again, it stems from that fear. So thank you for speaking on that earlier, Dr. D. And now, could you cover what are the best treatment options for women who have been diagnosed with GYN cancer?
Well, first, you have to go to the right specialist, right? So there's GYN oncologists, and we have, a GYN oncologist in our practice. But the GYN oncologist can give you the best treatment, discuss the best treatment options with you, because again, some cancers require not only surgery, but also care after that surgery. So sometimes you have to be referred to a person called medical oncologist if you, for example, need chemotherapy, or a radiation oncologist for radiation therapy. But it definitely starts with just talking to the right person who has the knowledge of GYN malignancies, and then still realizing that you don't have to have open surgery just because you were diagnosed with cancers. Minimally invasive surgery for early uterine cancer is completely acceptable and is actually the standard of care. Even for early ovarian cancers, you can do full staging procedure laparoscopically, and that allows the patient to recover. Because remember, if you're having to have treatment afterwards, there's a lot of anxiety with waiting. Right, I'm waiting because I have to heal from surgery to start my chemotherapy. With minimally invasive surgery, because recovery is so quick, you're back on your feet and you can start treatment right away without still feeling unwell, and recovering from a major surgery.
Mm-hmm. And how can CIGC help?
Yeah, so we do minimally invasive surgery, and as I mentioned, we do have a GYN oncologist, Dr. Paul McCool, and so we welcome all patients, whether they have the diagnosis of a malignancy or if they are concerned with their abnormal symptoms, even if no concrete diagnosis has been made. So really, we have kind of all the specialists. Or the ideal, I guess, specialist in one practice, because we provide minimally invasive surgery, but also have the expertise of GYN oncologists.
Mm-hmm. And sorry, I'm just reading the comments. So Nicole is saying, I haven't waited, but I think there is fear of the unknown, which there always is, right, with surgery. You have a certain expectation, but there's, it's not always definitive. Could you speak to that a little bit, Dr. D?
Sorry, can you repeat that question?
Nicole said that she hasn't waited, but she thinks there's a fear of the unknown. I think there's a fear of the unknown. And
yeah, I mean, definitely, that's an issue. I mean, I see it a lot in women who experience postmenopausal bleeding because they know something is wrong. They haven't had a period in 5 years, and all of a sudden you have bleeding. And to someone who is not experiencing that, it might be difficult to know. Well, why would you wait? Right? Something is happening. It's clearly wrong. Why would you not go to the doctor right away? But there is a lot of fear, a lot of anxiety. What if I have cancer? And it's kind of one of those things like, well, if I have cancer, I already have it, so I can't really change that, but I want to delay knowing about it. I mean, I think it's probably not rationalized like that out loud, but there might be some, just subconscious thought process that's happening that's preventing people from going. Because once like, that's it. It sort of solidifies it. Maybe until for sure, there's a chance that it's not there, right? That everything is fine. So, but definitely, again, I can say that the sooner the diagnosis is made, the better. It definitely can't make it worse, but it can make it better, and it can be a difference between complete cure with just surgery versus continued treatment versus no possible treatment.
Now, Lola James said, my delay was my last GYN. I'm assuming it's OBGYN. Said she would try a partial hysterectomy, but she stated she may possibly do a full hysterectomy, waiting on menopause, hoping my fibroids will shrink.
Yeah, I mean, that's a big misconception with fibroids and women who are sort of perimenopausal, right, late 40s, early 50s. They're thinking, okay, well, I'm almost there. I was able to go through all these years without having to have a hysterectomy. I'm just gonna like hold on, hang on in there for a bit longer. The problem is with very large fibroids, you're unfortunately are not very likely to see a huge change in size. So just waiting, it's going to be more of a disappointment, because these fibroids, while they are probably not going to get bigger after menopause, they're not going to get much smaller. Typically, they calcify or become very hard. But if it's a fibroid that's a size of a cantaloupe, it's not going to be a size of a pea, no matter how much older you are or how many years you've been in menopause. So there's just very minimal decrease in size, especially with these very large fibroids. They become calcified, they become hard, and it actually makes the surgery a little bit more difficult, because they're very hard to sort of take out, to cut. So I would recommend not waiting. If there are sizable fibroids, if they're actually causing issues, or again, if they're just large, it's best to take it out. And also, typically, if you're going to have surgery, you don't want to wait till you're 80 years old and you have maybe potentially have other medical conditions. It might just be much harder to recover even from simple surgery than when you're in your 50s. So I think the younger you are, the whole surgical experience may be much easier. And just knowing that, and knowing that things are not really going to change in the next 10 years, that would probably make you think about doing something about it now than later.
Absolutely. Seema said, I didn't delay getting my symptoms evaluated, but there was definitely a large window of waiting and experiencing my symptoms for a long period of time before I was properly diagnosed, because I couldn't find the right doctor. Finding CIGC was definitely life-changing. I'm so thankful to you all. It's been years and I'm still symptom-free.
Yeah, I mean, especially during COVID, I think delay in just even getting an appointment or getting surgery is a huge thing. But even other times, I see patients that said, "Oh, I came to see you because when I called the office, she was like, I was calling everywhere, trying to find an appointment, and I called your office and I got an appointment right away, but the doctor that I called before you said that they weren't accepting appointments until the new year." I mean, that's insane. I don't have any explanation for that.
Right.
But yeah, we definitely, we have Saturday office hours. We have, off e-visits, phone consults, and then in-person visits at 2 locations. So definitely in terms of access and the ease of making an appointment, that's very easy. Because the worst thing is that when you want to have the treatment, or you want to have the diagnosis, but you can't get an appointment. I mean, that's really, really bad, especially in this area. There's so many physicians. There really is no excuse for waiting 3 months for an appointment.
Absolutely. Just like in our previous Facebook Live event, the patient was told from a previous physician that she would have to wait up to 6 months out for her surgery.
Yeah.
And you ended up doing her surgery, actually. And
some hospitals now, they're still not even scheduling patients because of the backlog, right? Like all the surgeries that were canceled during COVID, they're just now getting to those. So the patients that haven't been scheduled, they're having to wait even longer. And with GYN conditions, whether there's a suspicion of cancer, diagnosis of cancer, or if there's pain and bleeding, it's not one of those things that can wait.
Right.
You really have to be able to provide care right away.
It's very time sensitive. Absolutely. Kristen said, I hope I said your name right, Kristen. I was afraid the doctor would I was afraid the doctor would just tell me it's normal. And then she did, even when missed periods every other month got added to that list. Also, I felt awkward talking about it. But at that point in February, I felt like I had to, just to be poked a little bit around my abdomen, which wouldn't really let her know if anything was wrong, and told it's normal. Yeah. Thanks for sharing.
Yeah, I think that's a very good point. I think, especially with pain and endometriosis, where there's nothing, a lot of times ultrasounds are completely normal. There's nothing concrete. And, here you are saying, I'm having pain, I'm having all these symptoms. And the doctor tells you, well, your exam is totally normal. So, I mean, there's the patient versus the doctor. But we know with endometriosis, for example, that's very common. Most of the time, ultrasound is normal, right? And so really laparoscopy, for example, is the next step. So it's going to the right person. And sometimes it's hard to know who to go to, right? Because you don't even know what's wrong with you.
Right.
But I would say, with GYN, whether it's benign or malignant, just looking for a specialist. And, the main conditions really are fibroids and endometriosis. So if you know that you definitely don't have fibroids, maybe endometriosis is sort of the default there, and then going to a specialist that specializes in that condition for help, right?
Kristen actually has a second part of her comment that I completely missed. She said, I fought with her until I got a script for a pelvic ultrasound, but now thanks to COVID, I haven't been able to get the test. Also, I had a question. In checking for ovarian cancer or cyst or PCOS, how important is it to get an actual transvaginal ultrasound as opposed to a regular pelvic ultrasound that is just on the outside of the,
Right. So first part, I mean, I'm not sure, Kristen, where you're located, but you should be able to find an outpatient facility that's open, right? So for pelvic ultrasound, you don't have to go to the hospital, for example, to get that test. That can be done at an outpatient radiology facility. Also, for example, our office, we have a sonographer, full-time sonographer in the office, so patients can get the ultrasound at our office. And a lot of GYN offices also have sonographers. So that's one. The second thing, pelvic ultrasound versus transvaginal, they're one and the same. So the way the pelvic, it's just ultrasound of the pelvis, and the transvaginal part of that study is almost always done. And that allows for closer look at ovaries and uterus. And typically the pelvic ultrasound starts transabdominally, where the probe is just on the abdomen, like a pregnant, patient looking at the baby. And then the second part is transvaginal, to further look at that anatomy. So ideally, pelvic ultrasound would include the transvaginal portion. Some patients who are, for example, not sexually active or decline that part will just have the transabdominal pelvic ultrasound, but you just have to realize that that's going to be much more limited.
Thank you, Dr. D. I have another question for our audience. For those of you with a GYN condition, was a minimally invasive procedure presented to you as an option in the beginning? And while you all answered that, I'd like to head into first thanking you, Dr. D. We are reaching the end of our event. Thank you, Dr. D. Ms. Hunter, Brianne's mother, mentioned that your nightly phone calls were the one thing that she had to hold on to while Brianne was in the hospital. And I know, Dr. D, you mentioned that it was during COVID, so her family couldn't be around her. But Ms. Hunter was there locally with Brianne, even though she couldn't be at the hospital. So thank you to you for being that connection for them. And do you have any last comments to share with us on Brianne, on GYN cancer overall?
I think, you have to find the right provider. I think, with OBGYN, it's a very sort of confusing specialty. And a lot of times there's a lot of focus on obstetrics and pregnancies. And a lot of times GYN conditions, in the non-pregnant patient get overlooked. But there are providers that just do, GYN, especially providers that do GYN surgery. So perhaps if you do have a GYN condition like fibroids or endometriosis, or if you suspect something like that, going to a specialist, right, that specializes in those conditions might be important. Even just going to see a GYN oncologist. It doesn't matter if you don't suspect that you have cancer, but typically GYN oncologists are more advanced surgeons. And even if you're in a place where you cannot find a minimally invasive surgery, you don't have any access to minimally invasive surgery, let's say you can't travel, if you're looking for a good surgeon, typically a GYN oncologist is going to be much more surgically skilled, and also, they're going to be very in tune with what cancers could be present, right, and how to test for them. So I think that that's an important message. Just if you feel like something is wrong, you have to find the right specialist. Also, if you ever are not sure and you just want a second opinion, and even if you say, I don't want to travel to Rockville, Maryland to have a consultation, we always we do phone consultation or e-visit consultations. So even if you just want to double check that what you're being told sounds right, or maybe you need some additional imaging and you're just not sure, we're always here for a second opinion, absolutely, even if it's just, again, if it's just a consultation.
Thank you, Dr. D. Lola did answer our question. She said, I was told to get a hysterectomy at first until I did research about UFE procedure. And from my understanding, Dr. D, UFE is just when they go in and it shrinks the fibroids. Can you provide some clarity on that?
So UFE is done by interventional radiologists, and it's a procedure that uses blood supply to the fibroids and injects small particles that sort of plug up the blood vessels. Because fibroids are dependent, they're tumors, right? And they're dependent on two things. They're dependent on blood flow to them, and then they're dependent on hormones, which is estrogen. Mm-hmm. So for growth, you sort of need both. After menopause, the hormone levels subside, but there's still blood supply to kind of keep that fibroid there. Mm-hmm. With the UFE, you have to be aware that, so there's kind of two things that they target. One is the symptoms like bleeding, and the other is the bulk symptoms. So if you have very, very large fibroids and you're having a lot of pressure and discomfort and frequent urination, back pain, because the UFE is mainly, they're stopping the growth of the fibroids, similar to what the menopause would do. You're not going to be likely to experience a huge change in the bulk symptoms. Mm-hmm. The main symptom that's targeted with UFE is the bleeding. So there is, it's possible to have significant reduction of bleeding versus not so much reduction in the bulk symptoms. Also, it depends on the size of the fibroids. Again, if you have small fibroids and you don't want to do hysterectomy, UFE might be a good option because you're stopping these fibroids from getting large. But if your fibroids are already very large, and again, you're having a lot of pressure from the size of these fibroids, you're not going to have these fibroids magically, shrink into pea-sized fibroids. So it's important to kind of discuss these expectations with the interventional radiologist, and kind of understand what are you expected to experience after, and how long it's going to take to get there, right? Because it's not going to happen overnight. When you have a hysterectomy, you're going to immediately not have those bulk symptoms. With the UFE, you may never get improvement, or it may take months and months to see even slight difference.
Thank you for that clarification, Dr. D. Seema said that, no, I didn't even know a minimally invasive surgery was an option, was never educated on it, so I didn't even think to research it. Well, we're glad that you did end up finding CIGC, Seema. So thanks so much, everyone, for listening in. We'll have a recap of this event published on our blog next week. Both the written article and a full recording will be available at innovativegyn.com/GYN Cancer Awareness. And just to reiterate what Dr. D was saying, please go to your well woman exams every year. Listen to your body. If something is off balance or offbeat, just abnormal, you know that. So listen to that and bring that up to your doctor. Always get a second opinion. And once again, thank you so much, Ms. Hunter, for allowing us to share Brianne's story. She seemed like a beautiful, fierce soul, and we're honored to have shared her story today. And one last thing before we finish off, we want to hear more about your health journey. We're still continuing to collect responses in our Women's Health Survey, which you can find linked at innovativegyn.com/GYN Cancer Awareness. Same link of the blog post. Thanks again, Dr. D, for joining us, and thank you for all our viewers today.
Thank you. Bye-bye. Thanks, Ms. Hunter. Thank you.
Thank you, Ms. Hunter.